Thank you for those kind words. Thank you to everyone at DI for giving me this opportunity. I'm going to be going into the topic directly, and my topic today is: Has novel technology solved issues with impaired awareness of hypoglycemia? Last session, also, we've had a lot of conversation about the new technology that is being used in diabetology. I'm going to be keeping my talk centered towards hypoglycemia and the use of technology there. We know that the prevalence of diabetes is astounding. Nearly 1 in 10 adults are having diabetes, and we are expected to reach 125 million by 2045. We have become the diabetic capital of the world, and not very proud of that, but it is what it is. Managing of diabetes is like walking a tightrope where we are trying to manage between hyperglycemia and hypoglycemia. Hyperglycemia has its own woes in terms of retinopathy, nephropathy, neuropathy, etc. And hypoglycemia comes in with psychosocial, financial, morbidity, and mortality as well. The closer we try to achieve our HbA1c goals of less than 7, the greater is the incidence of hypoglycemia. Hypoglycemia has been shown to be an independent risk factor for cardiovascular disease. That is well proven now. How are we going to reduce this is what my talk is. The state of glycemic control is suboptimal. We are aware of that. But the more disturbing part is that nearly 15% of the population who is actually monitoring is also not working on it. So, whether it is the inertia from the side of the patient where they are not monitoring, or the inertia from the side of the doctors where we don't respond to the hyperglycemia or the hypoglycemia that occurs. So coming to my main topic, which is what is IH? What is impaired awareness of hypoglycemia? It is the decreased ability to perceive the onset of acute hypoglycemia. It's an actual continuum in which different degrees of IH occur. And what is the cause of it? The cause is because of repeated exposure to hypoglycemia. And when this repeated exposure is happening, there is a resetting of the glycemic thresholds for cognitive impairment, for symptom generation, and counter-regulatory responses. What are the risks of this condition is obviously very severe hypoglycemia. The degree of hypoglycemia keeps worsening, and it can lead to sometimes critical and life-threatening damage. So before technology came in, the criteria which was decided to find out whether IH exists or no was the gold score and the Clark score. The gold score was actually a questionnaire based thing where the patient's awareness of hypoglycemia was looked into. It was a 7-point Likert scale where the patient had to answer questions. But a lot of time, if a person already has IH, they are answering these questions incorrectly. And that is where the problem started occurring, where it was being underdiagnosed. IH was being underdiagnosed. A score of 4 or higher was called as impaired awareness of hypoglycemia. Now, how can we overcome this with technology? Can it help? Yes, for me, it's a big resounding yes. With the use of CGMS and the automated insulin delivery systems, we have been able to bring that down. In the next 10 minutes, I think that's what I'm going to be discussing. We know that this I always tell my patients like HbA1c is a prognostic test. It tells you more about what your chances of getting complications. It can tell you nothing about what is the present state of your glycemic status. The blood glucose, the SMBG at any one particular time is like a photograph. It can't be repeated again. Even after 10 minutes, you'll get a different number. But if I need to know what is the fluid state of glycemia, that is where CGM comes in. If you look in this picture, you can see very clearly that the patient has been doing 4 and 5 blood sugars in a day. And when you look at this track, you're like, okay, the time and range 4 out of 5 are good. But the actual picture is the one which is there on the other side, where you see the huge amounts of peaks and troughs. And that is where SMBG can create a problem as against using a CGMS. The blood glucose results are only a static picture at any point and do not give a sense of continuity. What is the number, what is the intensity and duration of the glycemic excursions. Now, what are the benefits of CGM? I say it is an actionable test. Once we do this test, we know where to act, whether the hypoglycemic peaks or the hypoglycemic troughs. We will talk more about CGM. I'm going to be talking about a little of the clinical trials which are available. So this is the impact study where it was done with type 1 patients using the Freestyle Libre. And you can see that the time spent in hypoglycemia was 38% lesser. Nocturnal hypoglycemia came down by 40% and the time in range increased by 60 minutes per day. 60 minutes might not sound like so much, but if you see that it's being taken away from time below range, it's a huge number. The same study, when it was done in type 2 patients, this was a replay study. We saw equally good numbers here, where the time spent in hypoglycemia was down by 43%. Nocturnal hypoglycemia came down by 54%, and the time in serious hypoglycemia was down by 53%. The Freestyle Libre system also improved glycemic control and reduced hypoglycemic unawareness and hospitalization. So this was the ABCD audit. Sorry, the HbA1c reduction was 0.4%. The gold score came down from 2.7 to 2.4. The incidence of hypoglycemia was down by 40. What I'm trying to show you here are the multiple studies which are already proving that technology is helping in the reduction of hypoglycemia. This is a very significant part of the IAH factors which the ABCD audit looked into. There was a reduction from 28% to 18% in the use of CGM. The serious hypoglycemic events came down from 14 to 4.7, and the complete loss of hypoglycemia unawareness, the incidence came down from 3.7 to 3.2. These are really significant numbers. The next study, I want to show a few of the real world studies as well. So this was the relief study in which type 2 patients with more than 65 years of age who were receiving insulin therapy, when they were put on the CGM, what was the outcome of it? We can see that there was a reduction not only in the decay, but significant reduction in the hypoglycemias, and the total number of glycemic control, the greatest amount of time in range, increased significantly here. So the sensor-based glucose monitoring is associated with better outcomes. There is an increased TIR, there is the hypoglycemia reduction, there's a decrease in the A1C, the quality of life improves. There is a decrease in the hospital admission, and absenteeism also reduces significantly. So how are these helping? So the CGMS works because of the real-time alerts, the glucose trend analysis, and the reduced hypoglycemia frequency. Coming to the next thing which we are going to be talking about is the automated insulin delivery. This is something which is very exciting, where I'm going to be talking about the closed loop hybrid systems. But the AIDs, even the manual ones, they improve the glycemic control because they optimize insulin delivery and reduce the risk of hypo and hyperglycemia. They obviously reduce the hypoglycemic risk and increase user confidence in managing their blood sugar levels. This is what I actually want to talk about, the hybrid closed loop systems, or the 780G that we are talking about, how it has made such a huge difference in people living with diabetes. So the hybrid closed loop systems, they combine the benefits of an AID and the CGM, and they offer improved glucose control and reduced hypoglycemia risk. What are the main benefits for IAH here? The advanced glucose control, these closed loop systems optimize insulin delivery, reduce the risk of hypoglycemia, and also the personalization that can occur with this insulin delivery is they can adapt to individual user needs, providing a tailored insulin delivery and reducing the risk of hypoglycemia. I would like to talk further about this. Very nice slides here. This one, which was given by Medtronics, to explain in very simple words what is bolusing while using the SmartGuard technology. There are three major things. That is the safe correction bolus, the meal detection bolus, and the safe meal bolus module. So coming to the first thing, which was the safe correction bolus module. Over here, the system is targeted at 120 milligram per DL for correction, and it uses a model-based prediction to estimate the correction bolus which will result. So basically, when you're using a pump, there is a basal dose which is adjusted, and whatever corrections have to be put in either manually or it can be done automatically. The 780G helps do it automatically. It uses AI, it uses your CGM, and it uses the activated insulin which is there, as well as the sensor glucose values, for deciding what is the dose which would be given. The meal, we'll go into this. Yeah. So let me explain what is the safe correction bolus. So if you look at this slide, you can see that along with the bolus, whatever corrections have been put in, that would be the pink lines. Okay. That is the dose which has been pre-decided. But with the safe correction bolus, when it comes into action, it checks every correction bolus to see whether this can lead to a hypoglycemia. It uses a prediction model to predict the glucose trends which can happen after the bolus comes in. And if it is predicted to cause a hypoglycemia, it will automatically correct the bolus dose and there will be a reduction. So if you'll see the picture, the black lines is what the correction bolus was supposed to do. And if you look at the dotted black lines, that is what the system has done. It sees that with so and so amount of correction dose, the patient might go into a hypoglycemia. So it corrects it and gives a safe correction bolus. This safe correction bolus algorithm is based on three things. What is the current sensor glucose? What is the glucose rate of change? And what is the recent insulin delivery? So this is how it works. When the sensor glucose is seen and the correction bolus is going to come in, the auto correction gets triggered. It decides like, okay, what's going to happen at the end of 2 hours? If there's going to be a hypo, it'll reduce the dose. It'll further reduce it and finally only give the bolus which is not going to let the blood glucose go below 120. Now, what is the meal detection technology and how does it work? So in this system, that if someone has forgotten to put a correction bolus, any which ways, the system will use the current and past sensor glucose trends and it will detect a missed meal glucose. This can also happen if someone who is on the pump decides to eat an extra meal which has not been given a correction bolus for. The system will detect this meal based on the sensor glucose rising rate of change. It will automatically deliver a stronger correction dose, and while the sensor values are rising, it can give you a correction dose every 5 minutes. So it's not that only one single dose can go in, it might be more than one also. Now, what is the safe meal bolus algorithm? This is the third smart technology which is being used. That is, it checks the meal bolus to see if can potentially lead to a hypoglycemia. It uses the prediction model, and if hypoglycemia is predicted, the meal bolus will come down again. So this is a real life example where the insulin to carb ratio was 10. The patient puts in the information that he's going to be taking a 60-gram carb diet. So that's divided by 10. That would be 6 units of insulin were required. But the system checked the meal bolus to see if it can cause a low. And it predicted that the glucose trends related to this might cause a hypoglycemia, and it automatically reduces the correction bolus from 6 units to 4.5 units, and that's how the potential low was avoided. So the 780G comes with different settings. These are the settings which are the most recommended, and there's a for 80% TIR without increasing the chance of hypoglycemia. And this is what the real life performance of it was, where if you see that out of the 29,000 users, the 5,500 of them used these optimal settings. And if you can see, the GMI came down from 6.9 to 6.7, and the overall hypoglycemic indices did not increase. So we know that their wearables are revolutionizing diabetes management. They are giving a lot of benefits. And what are the major advantages of CGM? We already spoke about. To just speak of it in single lines, is it offers continuous monitoring. There is a trend analysis. There are customizable alerts in the Freestyle Libre 2 and 3. And there's an integration with other devices. They can sync with the smartphones, with the pumps, and also other health related apps. Along with the freestyle systems, now the Eversense CGM is coming in, which is going to be an implantable device and is going to work for 90 days. And there is also the Dexcom system, which is going to be for 10 days. I cannot end this talk without talking about the smart insulin pens, which are now available. They automatically track the insulin dose. They send reminders for your scheduled dose. They also track the remaining amount of insulin so that no one misses the dose. And they can sync data with smartphones and tablets via Bluetooth. The benefits are obviously improved adherence to the regimens and enhanced accuracy of insulin delivery. A lot of times, the wrong dosage is taken, where is one of the other causes of recurrent hypoglycemias. There is an increased convenience to insulin management. There's a personalized insight into what is the total insulin usage, and remote monitoring for healthcare can be used, whether it's the doctor or whether if it's a child, the parents can monitor remotely whether the insulin dose going in is correct or not. So the examples of this are the Novopen Echo, Lilly's is the Yumapen Luxura, Bigfoot and Omnipod are not there in India, but they are also having smart pens. The future developments are it can be integrated with CGMS, the AI-based smart uh, insulin pens which are there, they can be used for insulin dosing, and the expanded connectivity is going to help when they have been synced with other devices as well. I just like to make a point about the smart watches. They are non-invasive and they track blood glucose levels, but they are not reliable and they have not been approved by any of the regulatory bodies such as FDA as yet. But the future is here for us to see, and I'm pretty sure the way technology is moving, we are soon going to get that. And with a device which is looking at the reverse iontophoresis from your sweat glands is what they're looking at to check your blood glucose. I'm sure in a few years' time, this is also going to become a reality. But as of now, the FDA has issued a warning against the use of these smartwatches and smart rings to measure blood glucose values, citing the risk of inaccurate readings and potential harm to people with diabetes. So that's the end of my talk. Thank you very much for a patient hearing.